Hi there, welcome everybody to the discussion of the latest data which we brought from ESMO, from the European Cancer Congress, which took place this year in Barcelona. So my name is Eva Schumacher-Wulff. I'm the chief editor of the cancer magazines Mamma Mia, and we are discussing here the latest abstracts for patients today. And I'm very happy that Professor Harbeck is here with us to discuss the latest data, because she is a well-known expert in breast cancer for many years, and not only breast cancer. So I'm really happy and delighted we have her here to discuss latest data with us. Frau Harbeck.
Yeah, sure. Thank you so much for having me. It's a pleasure to do this together with you. And I think we picked very interesting abstracts, both because of new drugs and efficacy, but also because of quality of life and safety issues that we would like to discuss. Here's the disclaimers. The first abstract, in my opinion, but I may be biased because I'm the senior author on this abstract, is the Destiny Breast 12 study. The study is relevant for patients with metastatic breast cancer that is HER2 positive and who have progressed on 2 or less lines of prior therapy. And this study is particularly important for patients with brain metastases. So what did we do in this study, which I had the honor to co-chair with Dr. Nancy Lin from Dana-Farber Cancer Institute in Boston in the US? We recruited 504 patients with HER2 positive breast cancer, and half of the patient, about half of the patient, 263, had brain metastasis, and 241 had no brain metastasis. All patients received TDXD as their cancer treatment, and the study was designed when TDXD was approved in this setting, but not reimbursed everywhere in the world, and particularly not in Europe. So clinicians could bridge that time and offer TDXD to their patients. What we did was we looked at the two collectives separately. We looked at patients with brain mets and looked at the efficacy of TDXD in that population, and then we looked at TDXD in patients without brain mets. And we looked mostly at efficacy, but obviously also at the safety profile. Here are the results for the patients with the brain metastasis. What we see in the overall population is a median progression-free survival time, that is the time until the tumor starts to grow again, of 17 months. And median means that 50% of the patients even have a longer progression-free survival. And I think this is quite outstanding data. What we also saw was the objective response rates in the brain. And I think here it's important to explain a little this waterfall plot. Every bar is a patient with their metastases, and if the bars go up, and you can see that's only very, very few patients, then the tumor grew under the therapy, or at least didn't shrink. And if the bars go down, this reflects tumor shrinkage, and the numbers we can see below the waterfall plot. And I think I would like to highlight the patients with the active brain mets, that is brain metastases that have not been treated before, either never ever because they just occurred, or not for this progression, but they may have had previous treatment. And you can see in patients who'd never ever had treatment for their brain mets, we have 82% response in these patients. And I think this is fascinating data showing that we now have a drug, a medication that we give intravenously that can actually make tumors in the brain shrink. For patients who did not have brain metastasis, we also looked at the response rates, and we saw about 70% responding here. So also very, very good data. And response means that the tumor symptoms are less. So it's a very patient-oriented endpoint. And lastly, the survival data, and I think here it's important to see that at 1 year time, 90% of the patients were still alive, and really that didn't matter whether they had brain mets or not. So what we see here, due to the quality of the drug in fighting metastasis in the brain, but also outside, we see that for the overall survival, the brain metastases really don't matter that much anymore. With regard to side effects, I don't think this study shows any new data. We already know that T-DXd is a drug that has chemotherapy associated side effects, but what we see here, it doesn't really matter whether patients have brain mets or don't have brain mets. We have nausea, we have vomiting, we have fatigue, and we have hematological toxicity. Everything is manageable, and particular nausea and vomiting, we now know about it. We didn't know it when we started those trials, so we can now prevent this by giving more medication with the infusion of the T-DXd. There's one side effect that we're all worried about. It's not so frequent, about 12%. Mostly low-grade side effect is interstitial lung disease or pneumonitis, which is like a lung infection without bacteria, if you want. So it's an alteration of the tissue that causes respiratory symptoms. And unfortunately, in this study, there were 6 deaths due to ILD, which accounts for 2.3% of the study population. And 4 of these 6 deaths in the cohort with brain mets had opportunistic infections, which are some very rare infections that we don't usually see in patients with a healthy immune system. So what we saw in the Destiny Breast 12 was we saw a sustained and long-lasting effect, particularly in the brain, in patients with metastatic HER2-positive breast cancer in second or third line. The safety profile was is known, and we didn't observe anything unusual. And for everyday clinical practice, I think the most important message here is that we now have an antibody drug conjugate that is also effective in untreated brain metastasis. And now when we sit together with the multidisciplinary tumor board, with the radiotherapists, the neurosurgeons, and medical oncologists, we can decide whether it's better, if there's brain metastasis in the HER2-positive setting, to give T-DXd or to give local regional therapy. And just to be fair and balanced, there is another drug, a small molecule, a tablet, tucatinib, which is given with another chemotherapy as tablets, capecitabine, as well as an infusion, an anti-HER2 antibody, trastuzumab, and that's an effective approved therapy, and we usually rate this in third line and beyond, so 1 line later than T-DXd, and that is also effective in brain mets. So very good news for patients with brain metastasis in the HER2 positive setting, that we now have 2 drugs that are actually effective in the brain, and we can decide whether to do local therapy or medical therapy for these brain mets, and the outcome data are fantastic if you look at the 90% 1-year survival, independent of the occurrence of brain metastasis.
I don't think, to be honest, that you're too much biased, because this is, in fact, really great news for patients with and without brain mets. And there are more good news, I think, because finally patients with untreated brain mets are also able to participate in clinical trials, which was not the case for a long time. They were excluded. So now I think finally, they're included, and data shows that it's worth to also include these patients to offer therapy. Now, my question is, we always thought that medication does not reach the brain because of the blood-brain barrier, which is supposed to protect the brain. So now we have 2 drugs already that show an effect in the brain. So what's different in these agents than in former chemotherapies or antibodies or whatever used to be on the market, which was not effective in the brain?
What we know is that this so-called blood-brain barrier is disrupted when there is metastasis, and even more disrupted when there is already treatment, like a local-regional therapy, like radiotherapy, for example. Then we can measure higher amounts of drugs. We know this from trastuzumab, for example, from antibodies in the spinal fluid. So there is already some drugs penetrating, but apparently they don't penetrate in a high enough quantity, volume, in order to make a difference in the brain. And now with TDXT, but also with tucatinib, we have drugs that are able to penetrate even more. And so this is quite helpful as a therapeutic agent right now. What we don't know yet is whether they're also able in the same quantity to penetrate if there's no disruption of the blood-brain barrier. But next year, we're expecting some trials in early breast cancer in high-risk situations where TDXD was given, for example, after neoadjuvant chemotherapy. And there's also a trial in the US where tucatinib was given after neoadjuvant chemotherapy in high-risk situations. And if we see that in these trials, there's also a decrease of brain metastasis on first occurrence of metastasis, I think that would be very good proof that these drugs actually can prevent brain metastasis. For the time now, we just know that they're very effective in patients with a disrupted blood-brain barrier to accumulate in the tumor, probably also because they're very targeted, like TDXD targets the HER2 positive tumor cells and then delivers the chemotherapy there on site, and that may explain its efficacy.
So you said it targets the HER2 receptor. So how important is it to make a biopsy of brain metastasis? Because after all, we don't know really which biology brain metastases have. Like, do they always have the same biology, like metastasis in the body, or could they be different? And how important do you think before starting the therapy would be a brain biopsy, which I understood is not so easy to do because it's the brain and it's a surgery in the brain?
Yeah. So if it's the first occurrence ever of brain metastasis and there's no other metastasis in the body, I would like to know whether the tumor biology is the same as it was for the primary tumor, which was confined to the breast and axilla, if it's possible. So we ask our radiologist about the location and ask them whether they could do a biopsy, either a image-guided biopsy or the neurosurgeon, whether they would like to do an open biopsy. If it's dangerous, of course, we would treat according to the biology of the primary tumor. And in fact, HER2 positive tumors are very much attracted to metastasize to the brain more so than other tumors. Maybe just the triple negatives also very prone to metastasize in the brain. So if there's any danger, I would not attempt a biopsy. And the other thing is for TDXD in particular, we know, and we're going to be discussing this with the next few abstracts, that it also works in tumors that don't have a lot of HER2 on the tumor cell surface, but maybe just a little bit. So actually, if the tumor loses its HER2 receptor, at least partly, while migrating to the brain, that wouldn't be a contraindication to TDXD, because we know TDXD also works in tumors, what we call HER2 low, with a little bit of HER2 receptor. So with this specific agent, I don't think we desperately need a biopsy of the brain tumor. But as I said, for the first occurrence of any metastasis, it is always good to know, but we would never want to harm the patient. So only if it's safe because of its localization to take a biopsy.
Yeah. So one more question. In case of stable disease in the body, let's say there are other metastases in the body, like in the lungs or liver, and they're stable, but suddenly you would discover brain mets. Would you change therapy immediately and say, now we go to TDXD or to tucatinib in case, of course, there was another therapy ongoing and stable?
The guidelines say so far the guidelines say, I have to say, we haven't incorporated DB12 into our guidelines yet, but so far the guidelines say if the body is stable under the current therapy, we can do localized therapy like radiotherapy, surgery, or combination of those two for the brain metastasis and continue with the therapy that controls the body. And I would like to go for this approach, but there may be a case where we're not sure and the body doesn't seem to be all that stable. We have some indication that there is tumor load increasing, like maybe an increasing tumor marker or so. So it's also something where we would like to have more control, although there is no overt new metastasis. Then one may change to TDXD based on these data and not do the local regional therapy. So we now have these two options, and we have to discuss with our colleagues from radiotherapy, from neurosurgery, what would be the best option for this patient at this particular time point.
Many questions at this time, but I think about brain metastasis, we did not have the chance to talk so much in the past. So one more thing, if you have a patient, she has brain mets and you suggest to take a therapy like TDXD and to see whether it works in the brain, but she says, no, but in case it's not working, it's growing and I'm terrified and I'm afraid and I want to have this radiation, so I know that it works. So what would you do just in case a patient doesn't feel comfortable to wait whether therapy is working?
I would explain why I think that TDXD may be the better drug, because there's also some other metastases that need to have better control. And obviously, local regional therapy for the brain only works in the brain. That doesn't do anything to the liver or whatever. So I would explain. And if the patient is still very cautious and would prefer local regional therapy, then we would send her to the radiotherapist and let them explain how much volume they would need to radiate and what the side effects are. And then we can make a very informed decision together with the patient. But so far, local therapy is still a very good option, and it's not one or the other. We will need both. It's just a question of how to sequence. And of course, the patient always has the last word in saying, this is for me, and I know I cannot accept this. But we just have to give our arguments, and then we'll see what the patient will decide.
Yeah. So I think we continue at this point because we have more data about this drug, and so we will further discuss about other topics.
Thank you. So I now have two abstracts from the Destiny Breast 06 study, which is a study, as I discussed before, in HER2-low metastatic breast cancer. One about the quality of life data, and then another one on the pathology and how to stain for HER2 and how to evaluate the HER2 staining. So this is a study that was done in patients with hormone receptor positive disease and low or very low levels of the HER2 receptor, which we call in our terminology HER2 low or HER2 ultra low. And the study included almost 900 patients, 866 to be precise, with hormone receptor positive, HER2 low, ultra low metastatic breast cancer. And those patients could have had some anti-hormonal therapy, but no chemotherapy for metastatic disease. And patients were randomized between TDXD and chemotherapy of physician's choice, which is very effective chemotherapy. Our standards, so either taxane or the oral drug capecitabine. And the study that was presented at ESMO by Dr. Hugh was the quality of life data in this study, TDXD versus chemotherapy. And what we saw was that the quality of life was very well maintained with TDXT. TDXT here is the light blue curve compared to chemotherapy, and here for the first 31 weeks. And if we look at some symptoms like pain, for example, we see that there is a longer time till the pain gets worse with TDXT than with the comparator chemotherapy. If we look at other results of the quality of life, like physical functioning, emotional functioning, cognitive functioning, we can see that all the quality of life data favor TDXT except for the GI toxicity, the gastrointestinal toxicity like nausea, vomiting. I talked about this before. This is when we didn't know in the studies that TDXT was actually making symptoms just like chemotherapy. Now in routine clinical practice, patients with TDXT get 2 or 3 drugs with the infusion to prevent nausea and vomiting. So I would say that this doesn't happen anymore, or at least not so much. But again, I also like to see these quality of life data where patients actually fill in what we see also in the side effect table. So this is a quality check that patients actually charted down what was really bothersome for them. But again, the more effective drug TDXT is better for a lot of these items in the quality of life scale. So the conclusion of our colleagues was that the quality of life is maintained during TDXT. We have delayed deterioration of very important functions like physical functions, role functions, and also of some bothersome symptoms like pain compared to chemotherapy. I already talked about the GI symptoms. We have to keep that in mind when we do the daily infusions. And what it means for clinical practice is, first of all, the study showed, and that was presented earlier this year at ASCO, that TDXT is more effective than normal chemotherapy. We also know that effective co-medications are important to support patients and not have them feel those TDXT therapy associated symptoms. And we also see that TDXT is not just the more effective drugs, but it also reduces tumor associated symptoms in a much more effective way. So very, very reassuring data, go nicely with the efficacy data we saw at ASCO this year. The second abstract was looking at how HER2 status was determined in this study. And this is again about the Destiny Breast 06 study. And here we have all these tumor samples from the patients with metastatic disease. And we had localized testing as well as centralized testing. So here is a little cartoon of how you can imagine that this HER2 staining works. So if not all the cells have this brownish color, then we call it 2+, which is that there is some staining, but not a lot. 1+ would be just very few cells are stained, but more than 10%. And then we have 0, which is called ultra low if there is staining between 1 and 10%, and if there is no staining, we just call it HER2 0. So basically, we have HER2 low, which is staining in over 10% of the tumor cells, but not in all of the cells. And then we have HER2 ultra low, which is staining in 1 to 10% of the cells on the cell membranes on the outside of the cell. And then we have HER2 0, completely 0, where there is no staining. So again, what this study looked at and what we saw at the ESMO meeting was the correlation between localized and centralized testing. And there is just one number which I sort of boxed in a little, which was also highlighted in the talk. And there were samples that the local testing had said we don't see any staining. And if you look at those samples, which was about 349 samples, we saw that in the central testing, 123 tumors were found as having no staining, but the rest had some staining, and 140 were ultra low, so up to 10% of staining, and the others were HER2 low, which is staining between 10% and but not all around on all the cells. So this actually means that the concordance in the category HER2 low is about 78%. And if you have a HER2 zero testing, it's worthwhile to retest that sample, or to maybe look at another part of the biopsy in order to exclude that there is some testing which the pathologist just overlooked. And a very interesting table was the table which compared the efficacy versus the type of staining. And you can see here, it really doesn't matter. All the little circles are on the left of the one. That means that in all of these samples, T-DXd was better, whether it was the primary tumor or the metastasis that was stained, whether it was HER2 zero with a little bit of staining, 1+ or 2+, and also whether the sample was taken with a biopsy or with a surgery. So in conclusion, basically there is two learnings. One is, if we find HER2 zero on tumor tissue, it makes sense to stain again a different tumor tissue, or maybe just restain. If we have HER2 zero from an outside pathology, it makes sense to restain even that same biopsy, because the other pathologist may not have been aware of the ultra low staining and its importance. And once we have a HER2 low or ultra low status, that is enough for T-DXd indication, be it on the primary tumor or on the metastasis. And the last abstract I would like to highlight is an abstract on toxicity of T-DXd, and this is about patients who all received T-DXd, a large cohort from France, 600 patients with cancer, the majority breast cancer, HER2 driven, so HER2 staining all around on the tumor cells, and patients had T-DXd, and then the investigators looked at the frequency of this interstitial lung disease and what was done therapeutically, and how to move forward once you discover this. And again, interstitial lung disease is sort of like an infection without an actual bacteria, but it's an alteration of the lung disease that can be potentially life-threatening. The good news is it's not that frequent. We had about 11% of the patients, 67 out of 600, who had ILD. The majority did not have any breathing-related symptoms. The majority was very low-grade ILDs, grade 1 or grade 2, but unfortunately in 6 patients, so that would be 9% of the overall population, ILD led to death of the patient. The risk factors associated with getting this ILD is having had prior ILD, so that is important. I will talk in a minute on how we treat it. So if we are able to retreat, we have to watch those patients very carefully, because it may happen again. And also smokers are more likely to have ILD. What did the colleagues do for this ILD? And in 75% of the patients, T-DXd needed to be discontinued. In about half of the patients, they used corticosteroids, which is the regular treatment, and that improved outcome in about 60% of the patients. And in those patients where T-DXd could be readministered, the recurrence rate of ILD was around 43%. So basically in grade 1, which is just a finding on the CT scan, but with no symptoms, we could re-administer TDXD, but we have to be aware that ILD may reoccur. It mostly reoccurs early during the treatment in the first 2 to 3 months, and patients who are on TDXD longer, maybe for a year or so, or even longer, the likelihood of getting ILD that late on treatment is not so frequent. So I think our learnings from this analysis, but also from the TDXD registration trials, is that interstitial lung disease is an important side effect. It occurs in about 12% of the patients, and we need to recognize it early enough in order to stop TDXD treatment and start patients on corticosteroids. The imaging of choice would be a CT scan in order to see whether what causes symptoms, for example, is related to ILD, and then patients would receive corticosteroids in order to improve outcome. And what we do in clinical practice is we try to teach both our staff, also the nursing staff, as well as the patients about this side effect, because awareness and coming in early if there is some early breathing symptoms is important for the future course of this side effect. And with that, I hand over back to Eva for some more discussions.
Yes, thank you so much. So this was 3 really interesting abstracts. I want to come back to the nausea vomiting side effect. Like, I think also during last congresses, we understood how effective this drug is. Now we have to work a bit on adverse events. Now the vomiting and nausea, you said that during trials we didn't really know what to do, but now we have more experience. How important is it for you to understand the pattern of nausea and vomiting, like whether it occurs the days after the infusion? Because you see patients usually every 3 weeks when everything goes well, but then how important it is to understand whether this is the beginning or whether it comes after 1 week. Should patients have some kind of diary, maybe a digital one? What helps you to understand how to treat this nausea vomiting, which is very not nice for patients?
Yeah, I think it's very important to understand when it comes and how long it lasts, because there's basically 2 different type. One is immediately, like with the infusion or shortly after, and the other one is delayed, so at home maybe the next day or the day after, and then lasting a little bit longer. We have medications, we call this a 2-drug or 3-drug regimen, depending on whether we would like to just make sure it doesn't, nausea and vomiting doesn't occur early, like on the infusion or shortly after, or whether it occurs later. Then we give another drug which patients can also take at home. And there's also some other medications where there actually was a very nice paper by a Japanese group earlier this year where they looked at a drug that is used in schizophrenia, but at a very low level, and that was also able to reduce the nausea and vomiting, in particularly also the delayed one which occurs at home. So diary is important. There is tools to use, like there's digital applications in order so patients can enter that and remind themselves when they come see the doctor, or just have a regular diary and make some crosses into a calendar or so, and we'll have a look at that. So anything helps. If we know exactly what's bothering patients, we can help them better.
So it's important they report back, because otherwise you cannot help. Now, if we come to the testing, what I understood that in a way it depends now a little bit on the way the pathologists test the tumors on HER2 levels, which test they use, how they interpret it. So it seems a bit like, for me, it's not so predictable for patients which test is being used, because we are not in contact with the pathologist. And you said that if we get like 0, like HER2 0, we should maybe insist, or it would make sense to test again. But how can we know and understand that this is the right test, this is the right, pathologist who has experience with this testing? How can we trust, or, what can we do to make sure that if we are eligible, we have access to the drug?
I think patients do not need to worry about this. These are international data, and the studies were done some years ago. So by the time we now have the results, so basically we now have a much better awareness amongst pathologists as well as amongst clinicians about the importance of HER2 status for TDXD indication. And TDXD is also approved to be used in second-line chemotherapy in patients with this HER2 low tumors. So pathologists have known for now maybe 1 or 2 years that it's important that they look at the staining, not just whether it's a lot of HER2 staining, but also whether there is just a little bit. And the quality assurance systems in Germany have already incorporated quality assurance for the lower part of the HER2 staining spectrum. So I think all the prerequisites are there that patients can be assured that if their tumor is evaluated, pathologists will look very carefully for the amount of HER2 staining. And all those correlations from earlier days came from a time where it really didn't matter unless there was a lot of staining, like HER2 3+, whether there was staining at all. And I think it's very human if it doesn't really matter whether there is a little or none, that one sort of overlooks this and says, that's 1+, or that's 0. I don't see anything at first glance. So now the quality assurance has been installed in a lot of countries. So patients, I think, can be very hopeful that their samples will be examined and stained and interpreted with the right amount of accuracy. But it doesn't hurt to know this, that HER2 0 is not something that is in the tumor forever, but there's part of the tumor where there may be a little bit of HER2 receptor, other parts there is no HER2 receptor. So if you only have a biopsy from a couple of years ago, or if you have a recent biopsy which is HER2 0, it doesn't hurt to stain another part of the tumor or another sample, just in order to make sure. There's very good studies showing that if you have 5 different parts of the tumor or 5 different biopsies, one will eventually be HER2 low, and then the drug will work in the tumor.
Which is sometimes not so easy. So, but if you say we can trust that the first biopsy will be really checked good, so I think that's good news that pathologists really understood how important it is and do that job. Maybe one more question to the ILD. It's kind of threatening, and now everybody is coughing because we have some cold and some, COVID and other respiratory diseases. So, and we know that grade 1 ILD does not make any symptoms. However, if it's grade 2 and we have symptoms, it's already kind of a sign that we should stop TDXD and not continue taking it. But how do we discover grade 1 ILD? Would you do scans, CT scan, even without any symptoms to make sure that you discover it early? Or because waiting might be too late for continuing the drug, right?
Yeah, I mean, we know from the studies that they did CT scans every 6 weeks. This may be a little bit too much in patients who are responding very well and have to take this drug now for years to come. I think the data we now know shows that maybe in the first half year we have to be especially careful. And since we early on during the treatment also tend to look early, maybe not every 6 weeks, maybe every 9 weeks, in order not to treat with a drug that is not so effective for our patient. I think that coincides quite nicely that we look at least every 3 months in the lung, and if there is some signs of ILD, we would stop the drug look whether there's any symptoms, maybe give some corticosteroids, and then wait for the resolution of the side effect. So we do check independent of symptoms or not, but maybe not as often as in the registration trials, because if patients do really well, it's also a burden for them to come back for CT scans too often.
That's true. So I think we had a nice overview over mainly this drug and other drugs that work in the brain. We spoke about the HER2 positive and HER2 low and ultra low tumors, like all the tumors that have a little bit of HER2, but we have another discussion with about tumors that are hormone receptor positive. So we hope that this was interesting for you, for everybody out there, and stay tuned because we have more data coming. Again, from other congresses, but also from ER positive, hormone receptor positive tumors. So thanks a lot, Professor Harbeck, for your time. It was a wonderful discussion. And here there's more to come. Thank you very much.
Bye-bye. Thank you for watching.